a massive welcome to everybody out there from all of us at NB Medical in collaboration with Cancer Research UK. It is fantastic to have so many people joining us this evening. I wonder if it's because the summer has gone, it's now cold and dark and wet outside, so what else would you want to do with a Tuesday evening than sit back and enjoy an hour of free CPD courtesy of NB and Cancer Research. And we've got a real treat in store for you this evening because we are covering all things to do with lung cancer, which is a super important topic for us in primary care. So let's just do some quick introductions before we get started. My name is Kate Digby. I am a GP partner and trainer in a lovely practice in Cirencester in the southern bit of Gloucestershire. I have a bit of a portfolio spread across my week because I'm also a course organiser for our local VTS scheme and I'm clinical director for our PCN. And I've been working with NB now for many years presenting these courses, but I love doing anything related to cancer, so I'm super excited to be with you this evening. I'm not alone this evening. This is the other exciting bit. I have two co-presenters to introduce. So first, without further ado, let me hand over to Georgia so she can say hello herself. Good evening, Georgia. Are you there?
I am here. Thanks so much. Yeah, good evening, everyone. I'm really thrilled to be here. I'm a researcher at Queen Mary University of London. I'm really passionate about doing research about early diagnosis of cancer, and I've done a fair bit of research on lung cancer. So I'm really eager to share some of my research with you this evening.
That's fantastic, and we are very pleased to have you here as well. So thanks, Georgia. We will see you again in a little while. We also have another super important person to introduce you to, and that is the key, the linchpin of this evening's clinic, our wing person, James. So James, are you there? Would you like to say hello?
So, hi, good evening, everyone. Thank you, Kate. So I'm James Booth. I am a GP in Chelmsford, former partner, now sessional GP. And the reason I'm a sessional GP is that I'm also an LMC medical director, and I sit on the BMA's GP committee as well. And alongside that, I am a safeguarding GP, and as well as being an NB course presenter, I'm also NB Medical's safeguarding lead. So if any of you look at your our safeguarding materials, you'll see an awful lot of me, unfortunately. But I'm running the Q&A question box tonight. Lots and lots of you on tonight, so I'm going to do my best to get around as many questions as I can and really highlight some key learning in the gaps. But given how many of you there are and how much we've got to get through, I'm going to hand back to Kate right now.
Thank you very much, James. Again, we will see you very soon. So there you are. That's the team for this evening. Let me tell you what we have in store for you over the next 60 minutes. We're going to have a little look at some of the basic facts surrounding lung cancer, the bits that are really relevant to us in primary care. And we're going to consider some of the sort of recognition and referral thoughts around suspected lung cancer. Again, that's really relevant to us in primary care. Georgia's going to talk about this interesting concept of lung cancer in never smokers, and she's going to share some really interesting research on safety netting, specifically for lung cancer, but safety netting principles that would do us well, to apply to any situation we find ourselves in when there is that element of uncertainty. And finally, we'll just look at some of the upcoming sort of widening access pilot schemes, which are starting to roll out across the UK. And bearing in mind, all of you on this evening will work in diverse areas within the UK. I'm sure we've got people on from Scotland, from Ireland, from Wales, and of course from England. So you might have some of these local pilot schemes already in your area. And if that's the case, please do let James know where you work and what you've got going on in your area. It's really helpful to build a picture as to all the different pilots that are going on nationally in the UK. Now, as James says, he is manning the Q&A, so please do keep him busy. It's a lot of fun being a wing person on these clinics. There are some poll questions for you to get involved with. So again, please do engage with those. It's really lovely to just test the mood of the nation, so to speak, when we're asking the poll questions. And don't forget to check out the resources tab, which you've got on your platform there, because that is jam-packed with some really interesting links to useful bits of research, relevant to what we're presenting tonight, but also some really helpful takeaways for you to use in your day-to-day working going forwards. Okay, I think that's about it for the introductions. Let's get started, and let's start with one of these poll questions. So here we go. What stage of lung cancer is the most common stage at diagnosis here in the UK? Do you think it's stage 1? Do you think it's stage 2? Do you think it's stage 3? Or do you think it's stage 4? I'll just give you a moment to answer that whilst I enjoy a refreshing sip of water. It's really lovely when people answer the poll questions because it makes me feel that I'm not stood in my attic study chatting to the wall. So thank you very much for everybody answering that. Let's have a little look at the answers. Okay, so not many people think that it's stage 1. That would be too much to hope for, wouldn't it? That we're catching lung cancer at its earliest stage when it's most likely curable. Few for stage 2. The majority, so half of you, think it's likely to be stage 3. About a fifth plumping for stage 4. Well, let me share the answer with you. Because lung cancer is the third most common cancer seen in the UK. It makes up about 13% of all new cancer cases, and that, those number of cases is projected to rise in the years to come. Now, you can see from this graph to the right that stage 4 is the most common stage at diagnosis here in the UK. It's actually the most common stage by quite some considerable margin. And you can see just by looking at the graph that the lines that sort of are sort of dipping down from left to right, that's survival that you're looking at there. Because lung cancer is the most common cause of cancer death in the UK. It causes about 21% of all cancer deaths. And like many cancers, survival from lung cancer is strongly linked to stage at diagnosis. Because everyone is being diagnosed at stage 4, that means survival is actually pretty poor. The 10-year net survival is thought to be around 9.5%, and that's better for women compared to men. The really sad thing about lung cancer and the real challenge for us is that this survival has not really improved over the last 50 years. And clearly, if we want to try and bump that up, if we want to improve survival, to bring it more in line with some other high-income countries, then we're going to need to think about how we do that and how we can bring the stage diagnosis forwards. There's quite a strong deprivation link with lung cancer, and indeed we see there's a much higher incidence and much higher mortality in more deprived areas. Cancer Research UK think that there's around 14,300 extra lung cancer cases in England per year, which are associated with deprivation. So it's interesting to note that incident rates are lower in Asian, Black and mixed ethnicity groups compared to the white ethnic group. Lung cancer has by far and away the largest number of excess cancer cases attributable to deprivation. And you can see this again in this cancer research graph to the right. Lung cancer is streaks ahead of other sites of cancer when it comes to its sort of extra cases due to the deprivation gap, as seen in this data from England. And it's by far and away, it's by far and away the higher incidence that's seen with lung cancer is likely to be related to the fact that risk factors are more common in deprived groups, for example, smoking or obesity. Now, just interestingly, I always find this graph quite interesting because you can see down at the bottom, there are a few cancer sites that are actually less likely to occur in more deprived groups. But this is likely linked to inequalities in either access to or uptake of screening, because we know that those from more deprived groups are less likely to take us up on offers of screening, or testing, they're less likely to go for their tests, or indeed less exposure to sun due to their due to their altered travel behaviour compared to people in less deprived areas. And recent modelling suggests that if socioeconomic inequalities were removed, the percentage of cases diagnosed at stage 1 or 2 would increase by 1.6%. So that's not a huge increase, though it's notable to think if we could just remove the socioeconomic gap, that would make a bit of difference. When it comes to routes to diagnosis, around half of people are diagnosed via the GP. Okay, we play a pivotal role in making the diagnosis of lung cancer. A third are diagnosed via an emergency presentation, usually through emergency departments. But about a quarter of patients are diagnosed following a 2-week referral. Just shy of a quarter are diagnosed following a routine GP referral. So we do have a huge part to play. What we do know is those that are diagnosed following an emergency presentation, 61% of those are diagnosed at stage 4. So if we could at least reduce the percentage presenting as an emergency, we might go some way to improving the stage at diagnosis. Now, we know that lung cancer is hugely preventable. 79% of lung cancers are thought to be preventable, and we also know that trying to reduce the risk factors for lung cancer can have a massive benefit on other risks for other cancers as well. Let's just take the non-modifiable risk factors for a second. Age, of course, you can't do much about that. DNA damage that is sort of cumulative over time, that puts your incidence rates up as you get older. And in fact, incidence rates are higher in the age group 80 to 84. Family history is also really important. And this is certainly something that I wasn't particularly aware of, but the risk is 82% higher if your sibling has or had lung cancer. It's 25 to 37% higher if your parent has or had lung cancer. And that's completely independent of any personal smoking history. Of course, the big modifiable risk factor that we all know about is smoking, and that is attributed to about 70% of all lung cancer cases in the UK. Indeed, for British males, lung cancer death risk is 15 times higher in smokers versus non-smokers. And the smoking risk increases both with duration and amount of smoking, but it's duration of smoking that has the biggest effect. Another key learning point for me was actually smoking cessation can improve life expectancy. Obviously, smoking cessation at any point is a good thing, but even if smoking cessation is achieved after a lung cancer diagnosis, that can improve life expectancy. And that's a really important message to communicate to patients if you are having that conversation. Just briefly, other sort of risk factors that we know about, asbestos exposure, I guess, is the big occupational exposure that we're all aware of. But there are other ones as well, including silica, diesel engine exhaust, working with certain pesticides, and so on. Air pollution is another relative biggie. 8% of cases of lung cancer in the UK are caused by air pollution. Living near a major road is not good for your health because lung cancer death risk is higher. And indeed, the International Agency for Research on Cancer considers that diesel exhaust might well increase lung cancer risk in the general public. We've got environmental tobacco smoke is another risk factor. Now, this might only cause 1% of all cases of lung cancer, but it's one of the big risks for those who have never smoked. And of course, when we're talking about environmental tobacco smoke, we're talking about passive smoking in layman's terms. But the risk of lung cancer in never smokers is 31% higher than those exposed to environmental tobacco smoke either at home or at work. Finally, ionizing radiation. Now, ionizing radiation comes in many forms, and it is attributed to about 5% of the lung cancer seen in the UK. And you can go down an absolute rabbit hole of information when you start looking at radon exposure, which I haven't got time to do this evening. Suffice to say, if you're quite interested in radioactive degradation of uranium within the soil that we live on, then it's a great way to spend half an hour looking at the UK Health Security Agency website to find out how high your risk is in the area that you live. So let's have a little think about lung cancer symptoms now for a second, because trends in lung cancer symptoms and signs have changed within primary care. And there was a really interesting piece of UK research published in the BJGP back in 2020, looking at the trends in lung cancer presentation. And the researchers took GP records from 2000 all the way up to 2017 to have a look at what pattern of presenting symptoms patients who are diagnosed with lung cancer had. What they found was that actually more patients now present with vague symptoms such as cough and breathlessness. And consequently, the proportion presenting with hemoptysis has significantly declined. Lung cancer rarely presents with hemoptysis now. Just 4% of presentations usually are through a one of coughing up blood. So whilst hemoptysis is an important red flag, presentation with really vague index symptoms such as cough or shortness of breath is far more likely. Finally, let's have a quick look at the NICE NG12 recommendations, or the guidance that really forms our 2-week referral pathways at present, because it's fairly slim. You know, the patients that NICE recommend are referred on an urgent suspected cancer route are anybody who has an abnormal chest x-ray or any unexplained hemoptysis aged 40 or above. And they also recommend that urgent chest x-rays are organised for anybody aged 40 or above who have any of the following symptoms. For non-smokers, they need to have at least 2 of these symptoms. If they've smoked at any point in their past, they just need 1. And this includes symptoms such as cough, tiredness, shortness of breath, chest pain, weight loss or appetite loss, but also other more clinical signs like clubbing, lymphadenopathy, thrombocytosis, or suggestive chest signs. The challenge that we have really is that the symptoms we are most likely to see our patients present with are incredibly vague, and there is a really low specificity for any of those symptoms really to signpost us to think about a diagnosis of lung cancer. Indeed, they're incredibly common symptoms. We see them all the time in our day-to-day work in general practice. And of course, they're incredibly similar to other comorbid respiratory conditions that we also see all the time in general practice, such as COPD, heart disease, or indeed acute or longer-term COVID. And that makes it very difficult for us as clinicians, but it also makes it very difficult for patients as well. And it's worth really sort of considering the patient perspective here, because patients might not know when to seek help. If they've got other respiratory conditions already, they won't know when's a good time to take themselves to the doctor and ask for some more advice. Or indeed, they'll just put their new symptoms of lung cancer down to the symptoms which they are used to having second to their comorbidity. Some patients worry about the stigma associated to lung cancer diagnosis. Well, there is a stigma associated with developing cancer, with a history of smoking. Some patients are reluctant to attend. They really worry about that stigma and how it's going to affect them and affect their families. Or they might indeed fear the diagnosis or have a real pessimism of treatment attitudes surrounding the diagnosis. Because I think it's the general conceptual perception is that actually lung cancer does not carry a good prognosis. Many patients feel that actually the treatments are not effective. So what's the point in being diagnosed when all that's left to you if you do have that diagnosis is not necessarily anything that's going to help massively. So these are some of the reasons that patients might choose not to attend the GP surgery. These are some of the myths that we need to debunk in primary care to encourage patients to attend. And public health campaigns have helped with some of that. They certainly have improved help-seeking behaviours from patients. So in previous public health campaigns, we've seen at the time of the campaigns increased symptom recall, increased recognition amongst patients, an increased number of chest x-ray requests often accompany any health promotion campaign. It's interesting to note, though, that actually, despite that, there's been no significant change in the urgent suspected cancer referral numbers. There's been no significant change in the routes to diagnosis to date. Looking at the evidence around the impact of these health promotion campaigns on earlier stage diagnosis, and actually, when you look at the evidence, it's not clear cut. There's some good research that shows health promotion campaigns can improve the earlier stage diagnosis, can bring the diagnosis stage down, whereas other studies have shown that there's no real impact. So it's a real quandary when you're looking at the data that you can't get a clear consensus. Of course, our first line investigation, our first line for any patient presenting with symptoms will be a chest x-ray in primary care. And this has long since been a topic of many different studies looking at the sensitivity of a chest x-ray when you're trying to pick out lung cancer in patients with symptoms. And there was a good systematic review published in the BJGP back in 2019 looking at exactly that. So it pulled together all of the research to date and it concluded that the sensitivity for chest X-ray for detecting lung cancer is approximately 77 to 80%. Now, the bottom line, the take-home point from that for us to understand as clinicians is that chest X-rays could miss a lung cancer diagnosis in around 20% of patients. So the important learning point here is that a false negative chest X-ray may add to the diagnostic delays for patients who have symptoms in a suspected lung cancer scenario, and that if you have patients with symptoms who you are clinically concerned about, consider doing a CT scan, even if that first chest X-ray is negative, because there is that 20% risk of a false negative outcome. Now that obviously implies that that having primary care access to CT scanning is going to smooth that transition from going from a chest X-ray to a CT scan. And while some areas do have direct access to CT scanning, not all areas do. And that's an area, again, which I'd be really interested to learn more about. So let James know in the Q&A box whether or not you are able to organise a CT chest in patients that you have clinical concern about. Just thinking about the follow-up of these symptomatic patients, just some basic principles here is that if you have a patient with symptoms that you're clinically worried about, continue to follow them up until either those symptoms resolve or you have found an underlying explanation for them. It may be that you need to go back to square one and repeat the history and the examination, do some other non-invasive tests that you can do from primary care. And of course, communicate your uncertainty to the patient. Encourage them to come back if their symptoms come back, if they worsen, or if they develop anything new. Just basic principles of safety netting, which Georgia will go into in far more detail in a few minutes' time. Given that there is this 20% false negative rate with chest X-rays, it has been asked in the past whether or not chest X-ray is the most appropriate first-line investigation when you are looking at investigating a symptomatic patient. There was quite a useful prospective cohort study published again in the BJGP in 2021, looking at exactly this issue. So in this particular study, they found that the sensitivity for a chest X-ray was 75%. And they noted that although there is this 20-25% false negative rate, the reason that chest X-rays are a good first-line investigation for primary care is that the prevalence of lung cancer in symptomatic patients within the general practice population is still incredibly low. And that means with a negative chest X-ray, your negative predictive value for lung cancer is incredibly high. In this particular study, 99.7%. And that really is driven because negative predictive values are linked so closely to prevalence. The low prevalence of lung cancer in the primary care setting means the negative predictive value is high. And that means that chest X-rays are still the most appropriate first-line investigation, even if we are going to hold a CT scan in reserve for those patients that we are most concerned about. Final conclusion from this particular prospective cohort study, when we're thinking that hemoptysis is actually a fairly sort of unusual presentation for lung cancer these days, actually within this study, hemoptysis actually with the positive predictive value of unexplained hemoptysis was almost 3% in patients, irrespective of their chest X-ray findings. So this study did add weight to the NG12 recommendations of referring anybody with unexplained hemoptysis, and it also helped reassure us that chest X-rays remain the most appropriate first-line investigation. Okay, I'm going to pause there for a second. I'm going to hand over to James, and then George is going to take on the next bit. Over to you, James.
Thank you so much, Kate. And really, really interesting questions coming in. And I'm going to apologise preemptively if I don't get to answer all of them in the chat. They're coming in almost as fast as I can sort of Rick Wakeman style manage both my laptops at once. I think some really interesting points about other forms of inhalation in terms of cancer risk. We have questions about cannabis smoking, questions about vaping. Cannabis smoking, interestingly, is, whilst it's qualitatively similar to cigarette smoke, roughly speaking, it's twice as carcinogenic in terms of the chemical content of it. And it's well established that cannabis exposure is a potent lung cancer risk. And of course, cannabis smoking and tobacco smoking will very, very often go hand in hand. A good point about vaping to reinforce is that there's not good evidence yet that vaping causes cancer, certainly, but vaping is still comparatively new. But also really important to reiterate, of course, to our patients that vaping should be seen as something that is safer than smoking cigarettes, which it almost certainly is. But it's not safer than not vaping if you don't smoke. And lots of quite troubling stuff about young people taking up vaping now as a primary thing rather than the adjunct to quitting smoking, which I think most of us were quite happy to promote it as. One last question, actually, which I think is a really interesting one. This is a question from William Bostock, which is how often you should get CT scans in COPD patients who have these symptoms more or less continuously, which of course is true, that a lot of COPD patients are going to have constant coughs, lots of symptoms like fatigue and sort of systemic upset around it. And I think that really speaks to the great sort of challenge of looking after our complex comorbidity patients, which is that often we don't have clear guidance for that sort of question. So much of it comes down to our skill as experienced clinicians. And I think what we're looking for in these patients is a change, is something different about them. Does the patient feel things are different? Has the pattern of the symptoms changed? So while there's no evidence for, you should be giving a CT to your COPD patients every few years, I think that's where our clinical skills really come in, and where there's no substitute for an experienced clinician taking a history, examining a patient and going from there. But with that, I'm going to hand over to Georgia, and I will join you again shortly.
Thanks so much, James. Also to say I concur with everything you just said, which is completely evidence-based. What we all like to say is looking for changes that are different for the patient. It's really, really hard to make generalizable sort of rules about when certain people should be referred. We should just be trying to understand what's new and what feels different for that particular patient. One group of patients that I know you all find particularly challenging and can feel a bit like looking for a needle in a haystack is considering lung cancer for people who've never smoked. And Cancer Research UK asked us to do a bit of research a couple of years ago, trying to understand the differences between people with and without a smoking history in terms of their sort of approach to seeking help and being diagnosed with lung cancer. So I'm going to tell you a bit about that study, and I'm going to unpick a bit about the patient barriers, but also some of the system factors, and then sort of translate that a little bit, hopefully, into some useful tips for practice for all of you. Okay, so we called the study the Pearl study, and we did several things. I'm not going to go into lots of detail, but just so you know what this is based on, we did a scoping review of all available evidence. We also did interviews with lung cancer patients, 20 of whom had never smoked, some who had sort of formerly smoked and then given up, and then 9 who are current smokers. And we also interviewed some healthcare professionals from across the lung cancer pathway. We were asking all of them about their experiences of trying to manage a diagnostic pathway. And here's some of our findings. And I'm going to be talking a little bit about sort of what patients talked about, and then what clinicians talked about, and what the sort of priorities are for the system. And I hope this helps you to support your practice by thinking about things like, how do patients think about their own risk? How do they see themselves of being at risk? What kind of symptoms do they present with? And there are differences between smokers and never smokers, as you're probably kind of aware of from your daily practice. What kind of state of general health do they tend to be in, and how does that affect how you manage them in primary care? Their kind of pattern of health service use, and their general level of concern. How worried are those patients? without a smoking history. And then in terms of the system stuff, I'm going to have a little think about things like risk tools and guidelines and whether they're helpful or not when it comes to never smokers, how you can kind of rely on your clinical judgment to help you. And I know that a lot of you have sort of fears about doing undue harm to patients who are at very low risk. So I'm going to try and sort of allay some of those fears for you or help you navigate that a little bit. But I do acknowledge it's a very difficult area of practice. So one of the really fundamental things that we found in our study is that never smokers are just really unlikely to think of themselves as being at risk of lung cancer. And this is fundamental. So just to clarify, people who do have a smoking history often don't attribute coughs and other symptoms to lung cancer. That's kind of normal, but they are aware that they're potentially at risk, and that's really different. So it appears to change the way that they think about their symptoms and the patterns in which they seek help. And I think this is really probably to do with the fact that the messaging that links smoking and lung cancer is so well established that people who've never smoked, even if they know that sort of theoretically there's a tiny chance they might get lung cancer, they just cannot see themselves as being at risk at all. So all the people we interviewed who were diagnosed with lung cancer had never considered themselves to be at risk at all. And so let alone when they had symptoms, it was just not even in their sort of realm of possibilities that lung cancer could be an explanation, whereas that was not the case for people who did have a smoking history. So here's a little poll for you all to see if you have any kind of ideas about whether people who've smoked exhibit different help-seeking behaviours to people who don't have a smoking history. So take a minute to think about it, whether you think having a smoking history is going to change the way people seek help, particularly in primary care. So I'll give you a moment to have a think about your answer. And this might be based on something that you've witnessed in your own practice, or if you've read a wee bit about it. All right. One more second and then we'll see what you've all thought. So I'm really glad to see that you all think it's true. That's exactly what I'm going to tell you. So well done, everybody. Funnily enough, those of you who said no are not actually completely wrong in that there are a huge number of similarities in the way patients behave regardless of their smoking history. One of the things I wanted to draw your attention to is symptom interpretation. So for a researcher like me, what I call symptom interpretation is when you're sat at home and you feel like your breathing's changing or something feels a bit funny or you've got a cough that's too long. What do you kind of think's going on? What we found interesting is that the smokers in our sample experience quite dramatic somatic changes. So they tend to experience symptoms that really often counted as an emergency. So things like collapsing or, really experiencing quite dramatic breathlessness that meant that they felt they were sort of in immediate danger. And they also tended to have more than one symptom. So they were more immediately unwell, more obviously unwell, whereas the never smokers in our sample mainly had just one symptom or very, very sort of mild symptoms in advance of their diagnosis. So the way they interpreted those symptoms was obviously linked to how severe the symptoms were. Very few participants, irrespective of smoking history, attributed their symptoms to lung cancer directly, but smokers tended to attribute their symptoms to existing comorbidities or just being kind of severely unwell. So they were more worried about what was happening to them, whereas it was really easy for the people who'd never smoked just to attribute their symptoms to kind of mild seasonal illness. So it's a combinative effect. If you have more dramatic symptoms and the sort of greater feeling of worsening illness, that tends to drive your emotions, drive that anxiety that means, I'm going to call the GP tomorrow and just see what's going on. So here's something that you as GPs really need to know about never smokers. They really are more easily reassured by you. So something that we found is that people who had a smoking history really tended to stay on it. They, if the GP told them to come back in into which hadn't worked. They were back into keeping on top of things. And if that didn't happen, they were much quicker to kind of push for investigations. I know something's not right. Please, can you refer me? Whereas people who had never smoked just didn't really do that. They were really easily reassured by the GP, probably because on the face of it, they didn't believe there was anything really wrong with them. And if the GP didn't either, then that was fantastic. They went home anxiety free and kind of stopped thinking about their symptoms for a while. And of course, you can imagine that led to some really long delays in going back to see the GP. So unfortunately, that meant it actually took a lot longer for never smokers to be referred. So that's something to look out for in practice. And a bit about what you can do about that. One of the things that prevented them from kind of referring patients straight away is obviously, you have to manage resource and you have to manage harms and risks to your patients. And I totally understand that. So one of the things people were worried about was inappropriate divestment of resource, i.e. if we've only got a certain number of chest x-rays or CT scans to hand out or urgent suspected cancer referrals, it should go to those most in need. So I should be referring my smoking patients before my never smoked patients. We totally understand that. There was also a worry about unnecessarily exposing patients to radiation. There was a worry about surgical harm. So if they were going to have to eventually have a biopsy, or kind of exploratory surgery, there were professionals along the pathway who were really reluctant to do those kind of invasive investigatory procedures. People are obviously quite worried about NHS workload as well. So, we can't be referring every patient with a cough. And, there's logic to that because it would take a workforce that we don't have. And also that they would cause patients unnecessary anxiety from over-testing. And that is a really valid concern. We know that being referred on an urgent suspected cancer pathway does cause patients quite severe anxiety. So I can understand where those concerns have come from for particularly for GPs, but for everyone involved. They want to allay patients' anxiety as much as possible. But you've got to be a little bit careful about that, and I'll explain why in a second. Here are my tips for practice then for you. It's really important to encourage active patient involvement in making decisions. Even if you're not going to refer, you want to give patients that kind of agency that, if they need to come back and see you, that they will. So you need to increase their sort of understanding and perceptions of control about what's happening to them, why you might be trying a certain medication as a sort of first line response, why you're not referring them straight away. Patients in general tend to prefer active safety netting, so being given really clear instructions. I'm going to talk about that in a little bit in the next section. And that can really increase patients' vigilance. So making those patients who've never smoked just a little bit more vigilant to their symptoms over time, so they don't leave it weeks and weeks and weeks before coming back to you. A really important part of that is not to over reassure the patient. So try not to say things like, this is very unlikely to be a lung cancer, because you might unwittingly be causing a delay. And I know it's a needle in a haystack moment, and you want to reassure your patients and you want to sort of maintain your rapport with them, and for them to come out of your office feeling reassured. But sometimes you're unwittingly doing harm by making those statements. So what we would say is try to avoid personal risk statements like you are very unlikely to have lung cancer. But instead, if you want to reassure them, you can use population statements like, so people who don't smoke are at a much lower risk of lung cancer. So it doesn't make it about them. You're just talking about it at a sort of statistical level. As Kate was mentioning earlier, it's really important to have a low threshold for chest x-ray. So chest x-ray radiation exposure is really low, they're really cheap, and there's sort of really good availability. So if in doubt, if you're worried about that patient, just send them for a chest x-ray. So it's time for a little pause. I think I should hand over to James just to see if there have been any questions that we need to answer at this point before we move on.
Thank you, Georgia. And again, lots of really interesting questions coming in, and lots around the theme of diagnostic tests and when we should be looking to diagnose patients, and particularly around, had some interesting debate about thrombocytosis prompting further investigations, which actually, and I think that's a really important, there's a very useful BMJ guidance article from 2019 around this, that this is actually, once you've excluded inflammatory and clonal disorders, you really do need to actively pursue the possibility of an occult malignancy. And of course, the chest X-ray is key for that. Last question that's come in, this is an interesting one that I don't actually 100% know the answer to, which is if GPs don't have direct access to CT, can they refer into TLHC pilot if it's running in their area? Now, having had a quick look at the guidance for a couple while I've been trying to answer it, they have quite good open access for patients within their screening range. But of course, a screening test isn't a diagnostic test. So my instinct is to answer in the negative for that one, that if you believe a patient has symptoms, they should be having a diagnostic suite of tests rather than a screening test. But I'd be willing to defer to anyone who knows differently on that. Now, as a rule, there's a clear answer from Georgia there. So, screening and diagnosis are different, and by definition, screening tests are being done on patients who are asymptomatic. So I imagine that is not a pathway in. I think it's good questions for local commissioners, though. There was a really interesting variability earlier on in the questions about whether people do or don't have access to direct GP access to CT scanning, or the other thing, of course, we were talking about just before we started, actually, between the three of us, was vague symptom pathways. So I think a really good question to ask your local systems, if you don't have it, is to ask them why not. So with that point, I'm going to hand back to Georgia to take us through safety netting, which is, of course, something we all do every day. And it'll be really interesting to hear some new thoughts on it.
Yeah, we know that direct access to testing is really patchy across the UK, and it's a really big problem. So yeah, I think it's an issue for kind of local discussion. Thanks for asking me to talk about safety netting. This is a real passion subject for me, which I've done quite a lot of research on. I know you all know what it is, but I just want to check that we're all on the same page. Sometimes what with all the rest of it, there's different definitions of safety netting. So just to be clear, tonight I'm talking about that kind of verbal diagnostic strategy that you have that's sort of ensuring that patients don't drop through the net until, and you're sort of monitoring them over a period of time until you can explain their symptoms. So I'm not talking so much about referred patients or sort of keeping lists of referred patients at this point. Okay, so the things I want to talk about are, what does really, really good safety netting look like? It's something you all do all the time, but, especially from a research perspective, what do we know works for patients? And what's kind of tricky, or, what do we find going wrong at the moment, and what should we do about it? Sorry, my slide doesn't seem to be moving on. Anyone move it for me? Let's try that. Oh, thank you. I think I've gone too far. Okay, so why is safety netting so important? Kate raised the incredibly valid issue of vague symptoms earlier, and lung cancer is not the only cancer that presents with vague symptoms. You're not going to refer every patient at their first consultation for those symptoms, because it's just not going to look like a cancer when it comes in the door. And so safety netting is really the only answer to that problem of how do we manage that uncertainty in a safe way? How do we make sure that we don't send too many people for unnecessary testing and yet don't let them just sit at home getting sicker and sicker? And one of the things I think is interesting about safety netting is it's just happening all the time, everywhere. It's just that, I've spoken to some GPs who say I literally do it in every consultation, or I'm doing it multiple times a day. And it's seen as really important. It's actually endorsed in the NICE guidelines. They give some sort of tips about what should be included in safety netting. And yet it's such a tiny intervention. It's just a verbal intervention that you're trying to squeeze in at the end of a consultation. And, you're all human. So it's actually a pretty kind of fallible intervention in a way for such an important thing. So here's a nice guideline then, and I'm not going to read it all out, but you may have seen it before. NICE thinks that the sort of really important things for you to do are to tell the patient which symptoms to look out for and when they should come back. And you might want to write that down because they might not remember. And you also might want to check that if you've sent a patient for investigations that that you've reviewed that and that you've kind of acted on them. And you might want to agree on a time frame with the patient, like when they should come back, or you should encourage the patient to initiate that recontact when they feel they need it, like if their symptoms get worse. So NICE is covering a few different kind of issues there. It's covering symptoms and action and time frame. So what are the symptoms to look out for? What should you do if they come? And then like within what time? But actually, researchers looking into how safety netting works have taken a slightly different view. So here's a rather kind of busy slide, so apologies for that. This is based on a really fantastic bit of research that was sort of putting together lots of different studies to see what aspects of safety netting made it really work. And their conclusion was that it's much more than that. So it is symptoms, it is talking about action, it is talking about time frame, but there's so much more to it too. It has to be incredibly clear. You have to check that the patient's understood the symptoms that you're talking about. And we all know that health literacy is a really, really big problem. It's really hard to know if someone's understood, if they're nodding, for example, or saying, It's really good to document it. So not just for the patient, but also in your records to sort of make a note of what you've said. And there, I know that there are some codes for safety netting now, and it's really important to use them so you can track it. Also, ensuring some validation. So if we go back to what I was saying about patients who've never smoked earlier, it's really easy for patients to be put off coming back. If you say you're safety netting in a kind of passive way, research has shown that they might interpret it as a kind of brush off. So even though you are saying, do come back if it doesn't get better, and you mean it at the time, what the patient hears is, oh, the GP thinks there's nothing wrong with me and I don't need to come back. And that's a real problem because you're really at odds with each other at that point. It's really counterproductive. So trying to really give the patient some empowerment endorsement to come back to you is super important. I just wanted to highlight that Cancer Research UK have also got a really neat safety netting flowchart and lots of safety netting resources that I think in the sort of resource panel that you can have a look at as well. So one of the things that's really tricky about safety netting is that context is everything. So we all know that if you've got loads of time left in the consultation, you can say it perfectly. You can, make sure that the patient's understood and you can give a time frame and everything else. But we also know that if you're really pushed for time, or you've spent most of your morning with some really demanding kind of complex patients, then, the details are really hard to get in that time. One of the things that we found, and this is a sort of results from a study that we did, is that GPs are really, really good at getting the basics right all the time. So they use caring tone of voice, they use good body language, they're pretty good at using plain language, so not too much jargon, they're pretty good at using open-ended questions. But what you can see is that they're not so good at things like checking the patient has understood. So asking the patient to explain in their own words or making sure that they were clear. And that's the bit that really gets lost. So actually the patient could walk out the room not having understood what you've said. And of course, that means they just won't come back at the right time. Also, in this graph, the sort of the dark grey is in more affluent areas, and the light grey is in more deprived areas. So you can see that actually when GP's under pressure with a population that's experiencing more deprivation, got more kind of complex problems to deal with, they're actually doing this really important stuff less of the time. And of course, that's the population that need it the most. So really counterproductive, really counterintuitive, and just a sign that, you're all under so much pressure all the time that these things slip when your job gets harder, and we understand that. So what I wanted to bring to your attention is that this bit after the consultation is the bit that you're trying to work on. So it can be really easy to focus on just delivering a perfect sentence, a kind of just getting that magical sentence out so that the patient understands everything. But if we think about what we want safety netting to do, it's two things. We want them to understand what you've said, and we want them to remember it. Understanding isn't enough. Remembering is really, really key. So 2.5 weeks after they walk out of your office, we want them to do whatever it is you ask them to do. And so basically, I think of safety netting as a kind of memory intervention in some ways. And that changes the way we deal with it. So we might want to think about how we deliver the safety netting. And this is often what's wrong with the way it's delivered from my perspective is, it's often weak or kind of neutral with this missing information, makes it really hard to understand and remember. It's really, really hard to maintain consistency. If your workload goes up, you're going to be a little bit less thorough. That's just human nature. It's really easy for patients to interpret it the wrong way. And from a research perspective, a lot of safety netting guidance has just been put together by a group of people sat in a room, kind of talking about what they think is best, rather than hard evidence about patient behaviour. So we caution you to follow those guidelines with a pinch of salt. Okay, I'm just conscious of time. I just wanted to highlight again this really important part of safety netting, which is about the patient feeling seen and heard and taken seriously. This is really the kind of critical bit for me. That thing of patients not perceiving that they can return is such a critical part of what produces delays. So in all the studies that I've done, not just in lung cancer, patients are very quick to perceive that they have been dismissed and shouldn't come back and see you. So I just wanted to highlight that as a kind of really important point. Particularly if it's vague, safety netting can be perceived as sort of dismissive. So things like, if anything changes, then come back to us. That's too passive. And you need to be more kind of active in your statements and give a timescale. So, within 3 weeks, I would expect your symptoms to have got better. And if they haven't, you need to make an appointment to come back to see me or to see one of my colleagues. One of the problems is that safety netting is quite often delivered at the end of your consultation. So it's a kind of parting shot, and it may be seen as a cue by the patient that they should sort of get their coat and get out. And that's what we see when you watch kind of videos of GPs doing safety netting, is the patient literally gets their bag and leaves the room. And I know that that's an important part of your job too, is to manage your time. So I'm not saying that's a bad thing. So patients pretty much never ask questions for clarity. So you're going to need to prompt them. You're going to need to say, I've given you some advice to follow. Do you want to ask me any questions about that? Because patients will just take it as their cue to kind of get out the way. Okay, and another way you can support that is to use other tools. So I know lots of you use text messaging. It's really easy to develop templates for text-based safety netting. You might also have seen some of these paper-based tools that have been developed where you can kind of write the timescale and what to look out for on one of these sheets. And of course, there are also kind of electronic safety netting tools that you may have in your practice, like See the Signs. A lot more research is needed on those products would be my kind of high level overview. But if you have them, please use them, because they may help the patient to remember what you're saying. Currently, electronic decision support tools, it's a bit of a kind of open market. There are lots of them available. They're really under-evaluated, particularly in sort of hard quantitative terms. And they really work in completely different ways in the way they integrate with your electronic health record. You might want to play around with different ones and see which one suits you before you commit your whole practice to taking it over. One thing I wanted to highlight with you is that those electronic safety netting tools, and actually safety netting in general, works better if you can kind of develop a method for your whole practice. If you get patchy bits of different GPs doing different things, it just can often create duplication and extra work for you all. If you get the whole practice doing the same thing, whether it's keeping lists of patients that you're worried about or checking whether they've gone for their blood tests, or you get an administrator who's sort of helping you to check back with those patients over time, it just makes the whole thing much safer to distribute that responsibility across your whole workforce in your practice. So here are my tips for practice. Try to use more than one delivery method for your safety netting, so maybe verbal and text. Make active plans where you can. So try and get the patient to come back within a 2-week time frame rather than just whenever they feel like it. Ask the patient to repeat back the advice that you've given them and encourage them to ask questions if you've got time in a consultation, and consider whole practice interventions. How can you work together as a team to try and improve your safety netting? Okay, I'm going to pause there and see if there's any questions.
Hi. So I'm going to go through points quite quickly, I think, because it's approaching 9 o'clock. Really, really useful to hear such a rational approach to something that we do all the time and potentially can take a bit for granted. I think one point that really stuck out to me was about health literacy, and it also speaks to something that I've always sort of banged on about, which is literacy. Remember that over 15% of adults have level 1 literacy or less in the UK. Below level 1 means you probably can't read a road sign. Level 1 is the literacy equivalent of a 6-year-old. So it's really, really important when we're safe netting, especially when we're talking about illnesses that have a deprivation gap and the inverse care law is really fighting against us, that we make sure that our safety netting is appropriate for everybody. We might need to be safety netting. And that's obviously you could fill a whole presentation on that alone. But I think that's a point that really, health literacy point really resonated with me on this, and I think probably with all of us. But I'm going to move on now. We've had loads of really, really good points I'm working through in the chat, but we've still got stuff to get through. So I'm going to hand back to Kate just at our last part of the presentation to round us off for the evening.
Lovely. Thank you very much, James. Indeed, that was fantastic, wasn't it? Thank you very much to Georgia for all of that really fascinating information on both never smokers and lung cancer, and also safety netting. I'm just going to finish this evening by talking briefly about lung cancer screening and some of these fantastic pilots which are coming up. And you may be aware that other European countries, the US and Canada, already have an established CT lung cancer screening program using low-density CT scans as the investigation of choice. And back in 2017, the EU position statement recommended implementation of low-dose CT scanning should be started as soon as possible. Now, the National Screening Committee here in the UK chose not to implement a national screening programme, but instead what we saw starting in 2019 was a sort of a selection of pilot studies rolling out the targeted lung health checks. And these took place just in England and mainly in areas of socio-economic deprivation. So these are classically the sort of mobile CT scanners that you sometimes see in supermarket car parks if you work in an area of socioeconomic deprivation. And they targeted patients who were aged somewhere between 55 and 75, who were registered with a local GP and recorded as either being a smoker or an ex-smoker. Now, it's interesting, these were just pilots that when the targeted lung health checks started to pop up. And some of the observation from these TLHCs is that, perhaps unsurprisingly, uptake to invitations of screening was lower in the more deprived groups. And that mirrors what we see in other screening programs, because if you look at the data for bowel cancer or cervical or breast cancer, the uptake on screening is lower in more socioeconomically deprived areas. Now, the big change here in the UK was that June last year, the National Screening Committee recommended implementation of a national targeted screening programme for lung cancer. And they're going to look at exactly the same group of patients as the TLHCs did. So patients aged 55 to 74 who have a history of smoking. And the recommendation is that smoking cessation should be incorporated or integrated into this screening programme. So within England, where we have had some of these targeted lung health check pilots, these will be replaced now by targeted lung cancer screening. And the ambition is to cover the whole of England from 2030. Now, whilst we're not going to be involved in the rollout of this screening programme, we do have a key role to play, and that is to encourage informed participation for eligible patients. And be aware that some patients may be less likely to take up their invitation to screening, especially people from deprived communities, those who currently smoke, those who are older, or perhaps those with other smoking-related conditions. So our role really is to identify these patients and really talk to them about the importance of accepting their invitation to lung cancer screening. Our other role is to make sure that smoking history is accurate in everybody's medical records. And, that is just something that we should be doing as a matter of routine when we're seeing patients on a day-to-day basis. Now, finally, let's just have a quick look at some of the new pilots which are popping up. And I'll make no apology that we're going to run 5 minutes over, because I think it's really interesting to learn what is going on out there. We've got pilots which are trying to explore alternative routes into the healthcare system for those who are who face barriers or are having a real problem seeking the help that they need. And really, the ambition is to improve access for everybody who may have symptoms or signs of potential cancer. So one is direct referral into the urgent suspected cancer route by community pharmacies. And this is something that's going to be trialled, and pharmacists will be able to make that urgent suspected cancer referral based on perhaps medication buying behaviours of their patients, or indeed the signs and symptoms of possible lung cancer that patients might talk to them about in the pharmacy when they're picking up their prescriptions. That's one option, and it could be really interesting to see how that goes. The other models which are being piloted are these self-referral models. So patients will be able to bypass their GP and go straight to refer themselves in for investigation or specialist review. Sounds a bit ambitious, but perhaps it has the potential to improve engagement with those patients that we're desperately trying to reach. Now, the suggestions are being that we might be able to do that either they could do that online, they might be able to do that via phone or video consultation, or there might even be walk-in self-referral systems. And again, it'll be really interesting to see how well they go. One of the CRUK public omnibus surveys that was conducted just earlier this year asked about these self-referral models, and actually a third of patients that responded said they would consider a self-referral, though it was interesting to note that the uptake, or the suggestion of uptake, was lower in those from a more deprived background. So I think we're going to draw things to a close now and just make some final thoughts, final conclusions for this evening. Lung cancer is one of the most common cancers in the UK, but outcomes are consistently poor. And we know that we need to do something to improve this early diagnosis. We also need to be aware that the help-seeking behaviours of patients is influenced by all sorts of things, such as stigma, comorbidities, and fatalism. And perhaps, just being aware of that will enable us to talk to patients a little bit more about the importance of presenting should they develop signs or symptoms. Chest X-ray remains an important first-line investigation for us. So do request chest X-rays in anyone you are concerned about. But if that chest X-ray is negative and you have ongoing clinical concern about a symptomatic patient, consider doing a CT scan, or indeed repeating the investigations that you have already done. Think about active safety netting. Think about the way that you phrase your safety netting conversations, and see if you can really sort of be a bit more proactive in the terminology that you use to try and get patients recalled and patients understanding that they need to come back and when that should be. And as Georgia said, a whole practice approach and consistency across the practice is probably one of the linchpins of ensuring that safety netting for any patient, but especially those patients who may have symptoms and signs of lung cancer, is super important. And finally, lung cancer screening is on the horizon. It will be a targeted screening programme for those at highest risk, so smokers or ex-smokers. It is set to roll out in England by 2030. It will remain to be seen whether or not other nations follow suit. And whilst this is all being implemented, our role really is to ensure informed participation for our patients and to maintain our accurate smoking records. Now, I've already mentioned the resources tab, but I shall finish just to flag some of the excellent resources that are available for you to look through in the resources tab that have all been provided by Cancer Research. And really, I think that's all I have to say now. We've not got time to go back to James for final questions. So I will wrap it up by saying a huge thank you to Georgia for spending her time this evening. A massive thank you to James for answering all your questions. And just to flag that we've got a whole bunch of clinics coming up now that you might be interested in joining us for. Next month, it's inflammatory bowel disease. Then we've got dermoscopy in November. We're doing child exploitation in December. And then in January, I'm back with Cancer Research again. And in January, we are going to cover bowel cancer. So there is a lot for you to look forward to in terms of these NB clinics. When the webinar finishes, there will be a short survey. Please do fill it out. It's really helpful for us to see the feedback, helps us to hone our presentations and really bring you the best that we can of an evening. And all that I have to say now is a massive thank you for staying till the end. Everybody has stayed on. It's been absolutely fabulous to have you all with us. Hope you've enjoyed the evening and look forward to seeing you again soon. Bye for now.